Hi there, I'm Dr. Martin Benfield. I'm a GP trainer, and this video looks at negotiating during the consultation. This will be needed if a patient has ideas, concerns, and particularly expectations that don't match with the doctor's most likely diagnosis or management plan. A successful negotiation would be both doctor and patient finishing the consultation happy. The patient would usually feel happy if they felt the doctor has appeared both medically competent and taken their needs into account. Although patients may have come in with expectations, the vast majority ultimately want the doctor to give them the best advice for their health. That's why many patients are taken aback when an ICE question is asked in a way that suggests that the doctor is asking the patient to tell them what to do. For the doctor, we feel comfortable if we feel like we've come up with the correct diagnosis and have given the best evidence-based management plan. Where doctors sometimes struggle is when they are too rigid with guidelines. There is no guideline in the world that exactly fits with a patient's unique circumstances, so there's usually room to adapt guidelines. Ideally, most of the time the term negotiating isn't really appropriate, as your aim is to data gather sufficiently to be able to hand over advice that is already appropriate for the patient's personal circumstances so that they can make their own informed decisions. The need to negotiate is much less likely if you have used the skills already described in the previous videos. You've uncovered the patient's ideas, concerns, expectations, why they have these ideas, the effect the condition has on their life, and what they have tried already. In the ICE videos, we talked about understanding the patient's views in more detail. If you get an answer to an ICE question, ask why. You can then include this information in the explanation of the differential diagnosis and management plan, which should prevent a difficult situation at the end of the consultation where the doctor presents a plan the patient doesn't want. A first step will be routinely practicing these skills from the previous videos, including the patient-centered data gathering as described already, explaining your thinking, explaining more than one possible diagnosis, describing what will happen without treatment, and offering more than one possible plan. If you are routinely taking into account patient factors and offering more than one option, then there will be far fewer consultations where you feel you are negotiating at the end. Your next step is to regularly practice explaining the issues that need to be considered for the important decision to be made. So that decision might be to give antibiotics or not, to arrange an x-ray or not, to refer or not. The explanation can include describing what you are confident about. This symptom is definitely caused by the guidelines and evidence that you are using, the limitations that might be present, what you definitely can't do, and the uncertainties in the situation. What aren't you sure about? For example, will the symptoms worsen? Will the treatment help? Negotiating will usually come down to one decision to be made. To be able to negotiate well, it is good to be aware of both the patient factors described before and doctor factors. These doctor factors include how sure are you with the diagnosis? 90%, 50%? How important are the tests? Are they essential? Might they show something unlikely to change what you're going to plan to do? What are the benefits of the treatment options? Does it cure everyone? Does it reduce pain a little bit? Do you know the number needed to treat? And what are the side effects? Are they serious? Are they mild? Are they common? It sounds like a lot, but this is the sort of thing you should be computing every time you make a decision. You can now look for boundaries in your choice. Where is the line you cannot cross? This may be easy. So, for example, in many areas, GPs cannot order MSK MRI scans. You can't start sick notes in the future. Do you know if NICE definitely advise against using a medication? It's often not as clear as that. you may need to decide where is your line in the sand for feeling safe. For example, you would probably not feel safe prescribing diclofenac for a patient complaining of severe dyspepsia symptoms. So that's your definite line in the sand there. You'd probably be okay prescribing it if a person had a past history of the occasional mild dyspepsia symptoms. So somewhere between the definitely never and very mild, definitely would do. Somewhere in that spectrum is the point where, no, that's the point where I'm not comfortable. If it is possible for you to do the thing the patient wants, even if it's not following guidelines exactly or not what you would choose to do, then that thing is open to negotiation. The aim is for the exchange of information to reach a point that is as close as possible to the patient's best interests, taking into account both the patient's experiences and the doctor's knowledge. And I think this point is good to be aware of, to take the pressure off yourself. You are not attempting to bend the patient to your plan. You are assisting the patient to make their own decision that is in their best interest. To do this, you need to understand their point of view. Three main aspects in most decisions to be made are usually whether to do it or not, when to do it, and what is the safety net follow-up plan with that decision. Whether to do it or not depends on if it has passed your line in the sand. If it hasn't, then the patient can choose it after you've explained the issue sufficiently for them to make an informed decision. The when to do it is often the main tool in your negotiation, and the follow-up safety net plan is when you can put some boundaries into that negotiation. So let's look at two examples. These are simplified a bit, so don't look too closely at the kind of medical details. It's the phrasing and the skills that's really the focus. In the first example, a patient who had a cold is still coughing at 3 weeks and wants a chest x-ray. I found out why they wanted the chest x-ray in the data gathering, so I've built that into the negotiation in my explanation by explaining my reasoning and adding a compromise into the safety net follow-up. Okay, so let's have a chat about what's causing your symptoms and whether or not a chest x-ray might be useful. It seems pretty clear that you had a viral cold about 3 weeks ago that set off your symptoms, and although most symptoms have resolved, you're still producing a bit of mucus, and I think that's what's causing your cough. In fact, still coughing at 3 weeks isn't unusual. I can understand why you thought about chest x-ray with your father having had lung cancer. It's very reassuring. You've had no worrying symptoms like coughing up blood, and your risk is actually low with you never being a smoker. The national guidelines for arranging a chest x-ray is to arrange one if there's been an unexplained cough for 6 weeks. So even though your symptoms are explained, is it okay if we reassess your cough if it isn't improving in another 3 weeks? We can arrange one sooner if anything worsens or you get new symptoms. So let's look at that again and look at each section. Okay, let's have a chat about what's causing your symptoms and whether or not a chest x-ray might be useful. So this is a signpost that we have moved on to the management section, and that the chest x-ray is the decision to be made. It seems pretty clear that you had a viral cold about 3 weeks ago that set off your symptoms. So I've started with the thing I am sure about. And although most symptoms are now resolved, you're still producing mucus, and I think that's what's causing your cough. In fact, coughing at 3 weeks isn't unusual. So this is the uncertainty that I've given a hypothesis for. I can understand why you thought about a chest x-ray with your father having had lung cancer. So I've acknowledged and been positive about their concern expectation. It's very reassuring that you've had no worrying symptoms, such as coughing blood, and your risk is actually low as you've never been a smoker. So I've described the side of the argument against having a chest x-ray. The national guidelines for arranging a chest x-ray is to arrange one if there's been an unexplained cough for 6 weeks. So this is the guideline I'm expected to follow. Even though the symptoms are explained, is it okay if we reassess your cough if it isn't improving in another 3 weeks? So I haven't said no. I've suggested a delay, so the time when that thing will actually happen, and hinted that I'm bending the guidelines a little bit for them. We can arrange one sooner if anything happens that worsens or you get any new symptoms. So the follow-up safety net hands control back to the patient, so they know they could get a chest x-ray anytime if anything worsens before the 3 weeks. In this situation, there is no line in the sand for arranging the chest x-ray. The guidelines state 6 weeks, but you could request an x-ray early if you wanted. So our aim is to educate and hope they agree. If they don't, and really want it now because they're really worried, then the compromise could be that you could do the form, but ask that they wait at least another week before getting it taken, and maybe let them know you won't be allowed to request a chest x-ray every time they have a cough for 3 weeks with no worrying symptoms. This should still result in a happy patient, a happy doctor, and the patient has had some education and boundaries for future presentations. The second case is a person with acute sinusitis whose past experience is that antibiotics work for them. The NICE guidance is not to issue antibiotics unless a person is unwell with it, and consider them if not improving at 10 days. So in most cases, you shouldn't issue antibiotics, but you could. So the negotiation will involve explaining the evidence, but appreciation of the patient's own experience and current circumstances. I agree, you clearly have another episode of sinusitis. The difficult decision is that your experience as antibiotics seem to help, whereas the evidence from trials shows that symptoms usually get better after 2 to 3 weeks without treatment, and 15 people need to be treated with antibiotics for just one person to get better quicker, and that person only got better a day sooner than the others, and of course all 15 were at risk of side effects like looser stools. In fact, the national guidance is we should never issue antibiotics unless the person has a temperature with it or it's not looking like it's improving at 10 days. Obviously you're going away in a week, and that has pushed forward your need to get the symptoms better quicker. I'm happy to do the antibiotics prescription this time, but my advice would be only start them if you start getting worse at any time, or if there are no sign the symptoms are improving at 10 days. What are your thoughts on that? Great. Well, if you don't use them this time, if you get another episode, make sure you do start them if you have a temperature with a sinusitis. If you ever feel really ill with an episode, then make sure you contact us. So with this case, the patient is likely to be very unhappy if you've not issued antibiotics because they're worried the sinusitis is going to ruin their holiday. So the best realistic outcome is to keep them engaged by you agreeing to the prescription, but emphasise the symptoms that should trigger that starting the antibiotics, so that they may delay taking them and see that symptoms do improve without them, and educate them so they do know what to look for next time before contacting for antibiotics. If you decided there was absolutely no way you should be giving antibiotics for a patient, then your line in the sand has been crossed. You might want to start with the explanation with a phrase like, "This is a very difficult situation." You want to be very clear early about why the guidelines say you cannot issue antibiotics in this situation. There is national guidance that says we cannot issue antibiotics for sinusitis unless a patient has a temperature with it. Give some empathy about the situation. I understand you feel they've helped in the past, and you're going away in a week. And give a safety net follow-up plan that does give some power back to the patient so they don't feel helpless in this situation. Obviously, if your symptoms start to worsen at any time, then that changes things. So please let me know if that happens. If the patient doesn't want to leave without antibiotics, then you need to decide how confident you are with your line in the sand. Are you sure that you cannot give antibiotics, or could you give them but clearly state your advice of when to take them and advice for future consulting? You have a responsibility to do the right thing medically, but you do not want to be rigid with your plan and get it wrong. Obviously, documentation in the clinical record is also very important. A good way to improve this area is to use learning logs to reflect on any difficult decision you have had to make or negotiate. Use the ethical framework for that decision. What benefit could there be? What harm could be caused? Was the patient given the correct and understandable information to make an autonomous choice? And can you offer the same choice to everyone in that situation? Also think about what was the impact or point of view from the different people involved. What was your point of view about it? What was the patient's point of view? And anyone else who might have ended up being involved, receptionists, out of hours, doctors, pharmacists, family members, carers. By thinking about this, the next time you're in a similar situation, you'll be much more in control of the situation. Okay, I hope that was interesting and useful, and good luck.